My name is Dr. Ewan Gallagher. I am a critical care specialist and assistant professor of medicine at the University of Toronto. Over the next 20 minutes, I invite you to consider with me the role that conscience should play in medicine and in healthcare. I will focus especially on the issue of conscience and euthanasia. The role of conscience in medicine has become controversial in Canada over the last several years, partly owing to the legalization of euthanasia. Euthanasia, also referred to as medical aid in dying or MAID, is the act of deliberately and intentionally causing the patient's death upon their voluntary request. While euthanasia is legally permitted and available in Canada, a substantial number of doctors and nurses have serious ethical concerns about causing a patient's death. And these concerns are further heightened by the expansion of eligibility for euthanasia to include those with disabilities or mental illness. The regulatory authorities in 2 provinces have enacted a policy requiring objectors to arrange for their patients to see a provider who is willing to administer euthanasia. To many of those with ethical concerns, making such arrangements would make them complicit in the delivery of the procedure. The question of conscience is a question about individual professional freedom. Should individual doctors and nurses be free to decline participation in the delivery of euthanasia? When this question was litigated in court in Ontario, it became very much a question about doctors' rights versus patients' rights. But I submit that this way of thinking about conscience as pitting doctors against patients is a serious misunderstanding of the issue. Let's begin with an obvious question. Just what do we mean by conscience exactly? We can think of conscience as our personal moral compass. It shows us where we ought to go, and it pushes us in that direction. Conscience involves moral judgment. It is how you recognize what is right and what is wrong. Conscience is not merely a matter of personal feeling or personal intuition. It is informed by reasons and evidence. This means that conscience can be informed and reformed based on a growing understanding of what is right and wrong through reasoning and deliberation. Conscience is not merely a matter of personal taste or personal belief. However, conscience does also include moral feeling and moral desire. It is what makes us want to do right and avoid doing wrong. Our conscience functions as a means of moral self-evaluation. We feel good about doing good, and we feel badly about doing wrong. A troubled conscience is sometimes described as moral distress, the sense that you are doing something that you ought not to do, and the grief that you experience from this. Conscience, in other words, is at the very core of our humanity. This understanding of conscience helps us to understand a conscientious objection as an unwillingness to do something because you are sincerely persuaded that it is wrong. Doctors may sometimes decline to do something that the patient requests, and the reasons for declining are sometimes divided into 2 categories: a technical reason or a conscience-based reason. A technical reason generally runs along the lines of, "This won't work, and therefore I won't do it." An ethics or conscience-based reason generally runs along the lines of, "This is something I ought not to do, and therefore I won't do it." Some hold that it is appropriate for doctors to decline to offer treatment on technical grounds, but it is not appropriate for doctors to object based on ethics because such a judgment reflects the doctor's personal moral values. 3 important objections are raised against the exercise of conscience in medicine. First, that it imposes doctors' values on patients. Second, that it undermines professional standards. And third, that it denies access to care. All of these objections raise very important concerns that need to be addressed. And at the outset, I want to point out that each of these objections are themselves a kind of ethical or conscientious objection. Each is a statement about what doctors ought not to do. These objections are conscientious objections. As such, the very objections raised against conscience seem to require the exercise of conscience. So the real question then is not whether conscience should be exercised, but rather which kinds of conscientious objections are appropriate and which are not. So how do we differentiate between appropriate and inappropriate types of ethical or conscientious objections? What is an appropriate exercise of conscience in healthcare? Well, the answer derives directly from the doctor's professional obligations to the patient. Doctors are obligated as doctors to act for the patient's benefit in a manner that respects the patient's value. Therefore, if an intervention is beneficial and respectful, it ought to be provided. If, on the other hand, an intervention is harmful to the patient or disrespectful of their value, it ought not to be provided. For example, we ought to object to the provision of prescription opioids when they are not needed for pain, since they could do serious harm rather than good. Respect for conscience, therefore, is centered on the care of the patient. The conscientious doctor is committed to doing good for the patient and showing respect for the patient. This conscientious commitment to the patient directs and limits what the doctor ought to do. The exercise of conscience and individual moral judgment is actually routine in clinical practice. Every time a doctor declines to accede to a patient's request, even on technical grounds, they are actually making a conscientious objection. How so? Well, in medicine, a technical judgment actually entails a moral judgment. If an intervention doesn't work, if it won't benefit the patient, then it follows that I ought not to give it. It's inappropriate to intervene if the intervention is pointless and possibly harmful. In other words, a technical refusal really also becomes an ethics-based refusal. I would be violating my conscientious commitment to help the patient by offering or performing that procedure. Examples in clinical practice include giving antibiotics for viral infections, performing unnecessary invasive diagnostic procedures, or administering aggressive chemotherapy that won't help the patient's symptoms or improve their survival or quality of life. In all these cases, I have not only a technical reason, but also a moral obligation to decline to perform such interventions. As such, these are unavoidably conscience-based refusals. I can't offer this treatment because it would be unethical for me to do so. Additionally, many conscience-based refusals that are grounded purely in ethical judgments are also widely accepted in medical practice. For example, there are no objections to refusals on ethical grounds when those refusals concern sexual relationships with patients or selling prescription opioids. Doctors are expected to refuse such requests, not because they are not technically feasible, but simply because it would be wrong to perform such acts. These expectations are set out by regulatory bodies, and doctors are expected to conscientiously object to such practices. If they fail to object, it is regarded as professional misconduct. It is important to note that in such cases, there is no concern that the physician is imposing his or her values on the patient. Even if the patient is okay with having sex with his doctor, the conscientious doctor will decline on ethical grounds, and this is regarded as entirely appropriate. Moreover, denial of access to quote-unquote care is not a concern because these inappropriate actions are not regarded as medical care, even if sexual relations between consenting adults is legally permissible. Therefore, there seems to be no problem in principle with conscience-based refusals. So what then is the problem with conscience-based refusals to euthanasia? The problem arises when individual doctors and nurses object to something that the majority believes is acceptable or appropriate. It is conscientiously objecting to an intervention that many would offer that makes the objection problematic. So the real issue then is dissenting from the majority. Should individual doctors be expected to practice in accordance with the majority view, or should dissent from the majority view be permitted? Here's the issue. Ethics is not simply a matter of popular opinion. Moreover, ethics is not simply a matter of what is legally permissible. Just because something is legal and carries popular support doesn't mean that it's ethically acceptable. For example, there was a time when a majority of Canadians supported the residential school system, one of the most heinous crimes against humanity in Canadian history. Dissenting from the majority may sometimes therefore be a virtue rather than a vice. True moral and ethical justification derives only from persuasive moral reasons. To be conscientious is to arrive at convictions through careful deliberation and to be faithful to those convictions. Convictions based only on popular opinion or the law are not really convictions. Real conscience is based on persuasive reasons. As a consequence, the only thing that can properly compel conscience are compelling moral reasons, and it is in this sense that conscience is bound by reason. Therefore, we ought to dissent from the majority if there are persuasive reasons for dissent. In the case of euthanasia, there are several compelling reasons for doctors to object to offering it. These reasons all derive from the doctor's obligations to the patient, to benefit the patient and to show respect for the patient's value. For example, doctors might object to euthanasia because intentionally causing the patient's death is not consistent with a profound respect for the patient's essential and intrinsic value. It seems to us that you can't show respect for someone by eliminating them. Moreover, every member of the community, including those with severe disability and mental illness, is equally valuable. A willingness to eliminate some members of the community implies that they are less valuable or somehow less essential to the community. Thirdly, we believe that the purpose of medicine is to promote physical and mental health and function. Causing death seems inconsistent with that goal. And finally, by controlling pain and symptoms through a focus on palliative care, medicine can help patients to find and maintain their dignity and their significance. So if there are good reasons against euthanasia, why can't everyone agree? Well, I myself recognize that good reasons are offered in support of euthanasia, but I do not find them persuasive. And how different individuals weight these reasons for and against euthanasia reflects their deeper foundational beliefs and values. Conflicting foundational belief systems result in insoluble disagreements over ethical matters. These conflicting foundational beliefs reflect the moral pluralism of our society. Moral pluralism means that there is no shared, accepted final authority in matters of right and wrong. Contrast this with the role of science and clinical observation in resolving technical disagreements in medicine. Science is the shared final authority to which we appeal when we disagree over whether a treatment is beneficial. But because of moral pluralism, there are no readily available means of persuading others to agree with us in moral questions, for we disagree even on the very meaning and basis for morality. This does not mean that there are no moral truths, or that we have to disagree on everything, only that when disagreement arises, it can be very difficult to resolve. The fact of pluralism has important implications. First, it entails that there can be no moral or rational justification for coercing others to act as if we are right. Such coercion imposes one's own foundational beliefs on others. This is just as true for secularist foundational beliefs as it is for religious foundational beliefs. Second, it requires humility on our part. Since we cannot convince others of our moral positions, we must recognize that we could be wrong, and those who disagree with us could be right. And third, it demands mutual respect and toleration. So should doctors act in conformity to majority opinion, or should they act from their deeply held convictions grounded in reasoned deliberation? I contend that it is good for patients to be cared for by conscientious doctors and nurses who act based on conviction rather than from mere conformity to popular opinion. Acting from appropriate professional conviction upholds the priority of the patient over every other consideration. In every clinical encounter, the patient's good and the patient's value must be my only concern. If I am persuaded that something is harmful to patients, but I do it anyway to conform to popular opinion, then patients are at high risk of harm. I, for one, would not want to be cared for by a doctor or nurse who prize conformity over conviction. Accordingly, if you wish to change the behavior of doctors and nurses, you must change our convictions rather than merely coercing. We must offer persuasive arguments that an intervention is beneficial and respects the value of patients. And lacking such arguments, we must accept that they may not agree with us, that we have no right to expect their convictions to change, and that is good for patients if they are free to disagree with us. I will briefly address the second objection to conscientious objection. which is that too much professional freedom leads to wide and inappropriate variations in how patients are treated. Those who object to conscience on these grounds contend that the care and recommendations that patients receive should not vary according to which doctor they see. This is an important objection in that it is important to preserve professional standards and values. Ensuring that patients receive high-quality medical care no matter which doctor they see is essential to the trustworthiness of the profession in the public's eye. I would point out, however, that variation in practice is quite normal in medicine. This reflects reasonable disagreement among physicians on how one ought to manage a specific condition or clinical problem. This variation is resolved over time through the accumulation of persuasive evidence to suggest some optimal way of treating patients. And the fact of variation does not entail that patients can't trust the medical profession, only that there is uncertainty and disagreement about how specific problems should be treated and whether specific interventions are appropriate and beneficial. Moreover, freedom of conscience sets clear limits for itself. First, such freedom is limited by one's conscientious commitment to the patient. The conscientious doctor or nurse is committed to ensuring that patients receive the very best medical care for their benefit and out of respect for their value. This commitment means that one will not object to interventions that, when needed, are clearly beneficial. This would include, for example, blood transfusions, an intervention that is sometimes incorrectly cited as a reason why respect for conscience would harm patients. Nobody committed to the patient's health and welfare can, in good conscience, deny a blood transfusion when it would be of benefit. This does not, of course, mean that patients can't refuse transfusion, only that a conscientious doctor will not refuse to offer it. Second, freedom of conscience is about the freedom to decline to act, not the freedom to act however you please. Respect for conscience does not mean that you can do whatever you wish without professional or legal sanction. To be prevented from acting does not injure moral agency in the same way as being forced to act. Finally, I will briefly address the third major objection to freedom of conscience in healthcare. Some argue that freedom of conscience inappropriately denies patients access to medical care. This is perhaps the most important political problem attached to the issue of conscience. If the individual doctor objects, how will the patients get access? Some regulatory agencies have enacted a policy requiring physicians to refer patients to a willing provider when they object to providing the intervention themselves. And this is regarded by some as a reasonable compromise that ensures access for patients while avoiding the requirement for the objector to actually perform the action of concern. So how should we respond to the objection that freedom of conscience blocks access to care? I'd begin by pointing out that the objection actually begs the question. It is concerned with the secondary question of how to ensure access, but at issue is the primary question of whether patients ought to have access to the intervention under debate. Claiming that conscience inappropriately blocks access to care assumes that the intervention in question counts as good medical care. It assumes that the conscientious objector is wrong in their objection. The objector objects precisely because she believes that the intervention is not appropriate medical care. The question of how access can be ensured should only be addressed once the appropriateness of access has been established. I would note by comparison that there are no concerns about a lack of access to various interventions that everyone believes are inappropriate or unethical. Refusing to provide access to such interventions would be regarded as appropriate rather than inappropriate. Secondly, I would point out that a policy requiring effective referral implicitly recognizes that conscience matters. This policy recognizes the significance of conscience in that it recognizes that most doctors are unwilling to administer euthanasia, even though they are perfectly competent to do so. So it seems to accept that doctors should not be required to personally administer euthanasia. The policy therefore seems to accept that doctors should not be forced to do something against their will. The policy aims to respect conscience and to protect moral integrity to some extent. So the crucial question then is simply whether requiring an effective referral is a reasonable accommodation of conscience. The problem is that if euthanasia is unethical, then it's also unethical to refer a patient for euthanasia. An effective referral involves an intentional, deliberate, and proactive effort on the part of the doctor to arrange for the patient to see a doctor who will cause their death. A referral entails moral and legal complicity. Regulatory bodies and the law recognize the moral and legal significance of a referral. The historical example of Hans Asperger is instructive. Asperger was the Viennese physician who first described what was known as Asperger's syndrome. Recently, his name was removed from the disorder after it was discovered that he referred some of his autistic patients for euthanasia. Asperger did not perform euthanasia, he merely referred for it. Yet as Simon Baron-Cohen, writing in Nature, puts it, Asperger was complicit in this Nazi killing machine. He protected children he deemed intelligent, but he also referred several children to Vienna's Am Spiegelgrund Clinic, which he undoubtedly knew was a center of child euthanasia. So a referral is a morally weighty act on the part of the physician. If I am sincerely and rationally persuaded that euthanasia is unethical, then I ought not to refer for it. A policy requiring effective referral, therefore, does not represent a meaningful accommodation of conscience. Moreover, an effective referral policy is simply not necessary to achieve the goal of effective access. Nearly all jurisdictions where euthanasia is legal do not mandate an effective referral. Thousands of patients in Canada, the Netherlands, Belgium, and the United States access euthanasia every year without difficulty in the absence of any requirement for an effective referral. Organizations representing conscientious objectors have offered positive policy alternatives that would appropriately accommodate conscience. If patients have questions about euthanasia, conscientious doctors will non-judgmentally discuss the procedure with patients and answer their questions about what it involves. In the community setting, doctors and nurses who have a conscientious objection to participating in euthanasia could inform patients that they can access the service through a provincial coordination service if they want to explore it further. In healthcare facilities, doctors who have a conscientious objection to euthanasia could offer to transfer the patient to a different doctor who could make arrangements for the evaluation and procedure. Doctors who conscientiously object will not obstruct access, but they are persuaded that they cannot be the means of access. In summary, conscience in healthcare is really all about ensuring the very highest quality patient care. Appropriate moral objections in healthcare are motivated out of a conscientious commitment to the patient. As such, the conscientious doctor or nurse will not act in a way that we are persuaded is harmful to the patient or that disrespects the patient's value. Many conscientious doctors and nurses are persuaded that euthanasia is not consistent with a commitment to benefit and respect the patient, and requiring them to make an effective referral forces them to be complicit in an act that they reasonably regard as unethical. Enforcing conformity, rather than respecting conviction, will inevitably be harmful to patients. At the end of the day, conscience in healthcare matters because patients matter. Patients want to be cared for by conscientious doctors and nurses who are devoted to doing the right thing for their patients. Thank you very much. If you would like to get in touch with me with questions or comments about these issues, you can reach me at this email address.